Greetings everybody, my name is Dr. Sura. I'm an obstetrician gynecologist. I'm here today to talk a little bit about my experience as a recipient of the Queenan Travel Award that allowed me to travel thousands of miles from Nairobi, Kenya, all the way to Grapevine, Texas, to be a part of the SMFM this time last year. Just to familiarize everybody with who I am and where I come from East Africa, Kenya. I was born and raised in the capital city of Nairobi. Our national language is Kiswahili, and English is spoken in most parts of the country. We have 44 tribes with 44 different dialects, but the most common is Kiswahili and English. Kenya is a hidden gem with some of the most beautiful beaches and wildlife attractions. I can say we're the only country in the world with a national park in the city center. So if you do fancy a break with the lions, that's just a drive away. We have a population of 50 million now. Sorry, that's a typo. The health system has levels of hierarchy, with the highest being the national referral hospitals and private hospitals, and our lowest level being the community services. We have 5 national hospitals, with the Kenyatta National Hospital being the oldest and located in the capital. I must admit the public health facilities are often overloaded and under-resourced, but we have a dedicated team of health workers, always ensuring their best for the patients. Majority of my training and work experience was at the Kenyatta National Hospital. This particular project was completed at the hospital. As mentioned before, it's the largest hospital in Kenya and situated within Nairobi, approximately 4 kilometers from the city center. Being a national referral hospital, it receives high-risk patients, self-referrals, and many unbooked patients from Nairobi and its environs. It serves as a teaching hospital for the University of Nairobi, undergraduate and postgraduate for the College of Health Sciences. It also serves as a training center for nurses and clinical officers. I believe we train 30 residents per year, and this number has since been increasing over the years. Our obstetric unit is managed by the Hospital Obs-Gyn Unit in collaboration with the University of Nairobi Department of Obs-Gyn. We have daily antenatal and postnatal clinics, seeing almost 100 patients per day. We have 3 antenatal postnatal wards with almost 100 bed capacity each. It is one of the busiest labor wards in the country, averaging 13,000 to 16,000 deliveries annually. The labor ward has 2 dedicated operating theaters running 24 hours a day, and they average about 16 to 20 cesarean sections per day. The pediatric unit runs in a similar structure. We have a large newborn unit, and we also have a neonatal ICU with a 10-bed capacity, limited ventilators. We do have provision of surfactant, but most patients are unable to afford this service. This project was part of my dissertation, and having a slightly keener passion for maternal fetal medicine, I was really keen to see it through. It was a randomized control trial exploring the effect of umbilical cord milking versus delayed cord clamping on selected hematological and clinical parameters in preterm neonates at the Kenyatta National Hospital. It was supervised by this amazing team, Dr. Gashuno, Dr. 𝗖𝗄𝗃, and Dr. 𝗥𝗲𝗄𝗃. They were the obstetrician gynecologists supervising me, and Professor Rachel Musoke was the neonatologist on the team. As we look at this slide, I want us to appreciate the global burden of preterm deaths and the 1.1 million deaths yearly attributed to its complications. We in sub-Saharan Africa make up 81% of the worldwide prevalence, with Kenya's national preterm birth rate of 12.3% and locally at Kenyatta National Hospital 18.3%. A global call to action to end preventable deaths of newborns by 2030 is embodied within the Sustainable Development Goals. Anemia of prematurity is prevalent in almost all prematures, which contributes to short-term and long-term complications. That brought us to the core of our study. Have we optimized placental to newborn transfusion methods, where we can take advantage of the reservoir of blood the placenta holds? DCC is recommended by major obstetric societies, with less exploration into milking, which has the potential to be as effective and faster, being advantageous especially when a neonate requires resuscitation and delivery needs to be expedited. There is a risk of overtransfusion, polycythemia, hyperbilirubinemia, and jaundice, which exists for both transfusion methods. The additional blood obtained through placental transfer can improve hemoglobin at birth, stabilize neonatal transition, and reduce rates of blood transfusion and increase neonatal iron storage in preterm neonates. This brings us to why we carried out this study. Umbilical cord milking has not been explored in our setup. Our busy maternity, which represents a lot of maternities in the periphery, milking could prove to be a safer, faster way of placental transfusion, achieving equal if not better hemoglobin at birth. Our study could serve to inform current obstetric practice and policy on this placental transfusion method. Our objectives were to compare the mean hemoglobin and hematocrit values within 24 hours of birth, the proportion of neonatal polycythemia within 24 hours, the proportion of neonatal jaundice within 1 week, and the proportion of neonatal anemia within 24 hours. This, of course, was all in preterm neonates between 28 to less than 37 weeks, undergoing cord milking versus delayed cord clamping at vaginal or cesarean delivery. As mentioned earlier, this was a randomized controlled trial, single-blind, done at the Kenyatta National Hospital on preterm neonates between 28 to less than 37 weeks gestational age. We took about 1 year and 6 months to collect data, where the intervention was umbilical cord milking and the control was delayed cord clamping. For our study procedure, women were enrolled at the onset of spontaneous labor. We had a cutoff of less than 7 centimeter dilation if they were in labor, or at the time of decision for a medically indicated delivery. Consenting participants were monitored through labor, and randomization was done when delivery was imminent or at the induction of anesthesia for cesarean sections. For neonates that underwent cord milking, the cord was pinched closest to the placental end and milking was done toward the neonate. The cord was released and allowed 2 seconds for refill. This served as one milking motion and the procedure was repeated 4 times. For neonates in the delayed cord clamping group, the cord was clamped and cut after waiting 60 seconds. In the event neonatal resuscitation was required, immediate cord clamping was implemented. Follow-ups were at 24 hours and at 1 week, depending on the data that needed to be collected. Entry criteria included mother-baby pairs between 28 to less than 37 weeks gestational age. We excluded pregnancies with multiple gestations, neonates with congenital abnormalities, rhesus-negative mothers, HIV and VDRL positive women, antepartum hemorrhage including placenta previa and placenta abruptio, women in advanced stage of labor, that is, more than 7 centimeters dilated, were excluded. Pregnancies in which neonates required resuscitation is a priority. during the antenatal and immediate postnatal period, as well as patients who were unwilling to go randomization, were also excluded. The sample size was calculated on a basis of a previous trial done, and we came up with a figure of 128 participants per arm. To account for attrition, an additional 10% was added to the total sample size. Therefore, 280 participants were required for the study, 140 in each arm. The biostatistician participated in the study design and performed all the analysis and was blinded to the allocation groups. We used a modified intention to treat analysis, where some patients who were deemed ineligible after randomization, or certain patients who never received the intervention, were excluded from analysis. Continuous variables were compared using two-sample t-tests, and categorical variables compared using chi-square tests or Fisher's exact tests. Outcomes were compared between the two arms using t-test for continuous variables and chi-square test of independence for categorical variables. A p-value of less than 0.05 was considered statistically significant. All statistical assumptions were met, and validation of final analysis was done. The trial was registered at the Pan-African Trial Registry. Approval was sought from relevant bodies. Our ethical board approved the study. The study was monitored by the Data Safety and Monitoring Board. And to our results, initially 344 were assessed for eligibility. We excluded 64 for relevant reasons. 53 did not meet the inclusion criteria, and 11 refused to participate in the trial. 200 were randomized in total, and eventually we had 128 in the DCC arm versus 132 in the UCM arm that were included in the final analysis. 12 in the DCC arm did not receive intervention due to birth asphyxia, congenital anomaly, and meconium aspiration syndrome. And in the UCM arm, 7 did not receive the intervention due to birth asphyxia, congenital anomaly, and 1 neonate had an injury at birth. We lost 1 to follow-up as the mother refused bleeding of the neonate and data was unable to be retrieved. My apologies, the slide for baseline characteristics is missing, but the intervention and comparison groups were equivalent on observable characteristics. Majority of the mothers were above 25 years old and attended antenatal clinic from a facility outside Kenyatta National Hospital. The mode of delivery was comparable with both arms receiving equal numbers in spontaneous vaginal delivery and cesarean deliveries. This showed randomization was effective. Neonatal characteristics were also comparable in both arms. The majority were late preterm and low birth weight. We had equal sex distribution. I forgot to mention earlier that gestational age was confirmed with either a last menstrual period or an obstetric ultrasound that the mother had done. We went a step further and tried to confirm gestational age by doing a Ballard score at 24 hours of birth. A Pearson score showed a very strong correlation, so I guess we can say our gestational age estimate was quite accurate. More to our specific objectives, the study showed the means were similar for hemoglobin in the umbilical cord milking arm and the delayed cord clamping arm. Same noted for the hematocrit in both arms. There was no statistical difference noted. We defined neonatal polycythemia as a hematocrit concentration more than 2 standard deviation above the normal value for gestational age. So in this study we used gestational age specific reference ranges. And here we can see that polycythemia at 24 hours was more prevalent in the DCC arm at 8.6% versus 2.3% in the UCM arm. A statistical significance was noted. In this study, neonatal jaundice was clinically determined. With assistance from the pediatrician, who was part of the study team, clinical examination of the neonate was carried out, observing for yellow discoloration in the periphery of the ocular conjunctiva and in the oral mucous membranes. This was guided by pictures and videos on how to detect jaundice. Neonatal follow-up was until 1 week after delivery. We can see that neonatal jaundice was noted to be prevalent in the DCC arm at 15.6% versus 6.8% in the cord milking arm. A statistical significance was noted. Also for neonatal anemia, we used gestational age specific reference ranges, and we defined anemia as hemoglobin concentration less than 2 standard deviation below the normal value for gestational age. Here we can see the proportion of neonatal anemia showed no difference in both arms. Just to summarize, UCM did not show statistical or clinical significance in the mean hemoglobin and the mean hematocrit and the proportion of anemia in 24 hours. However, DCC was associated with an increased proportion of neonatal polycythemia and neonatal jaundice. At the time of the study, about 4 trials had been completed. While our findings for hemoglobin and hematocrit were similar to these trials, they did report a much higher statistically significant hemoglobin in the UCM arm. Although our gestational age was much wider and our mode of delivery included both caesarean section and spontaneous vaginal delivery, this might have accounted for this contrast in findings. Our increase in neonatal polycythemia compared to other studies might have been because we used gestational age-specific reference ranges that might have increased our threshold for detection of polycythemia. Most studies used a blanket figure of 65% to define polycythemia. Neonatal jaundice has been highlighted as a risk of placental transfusion. Our study showed an increased prevalence in the DCC arm. This was a clinically based finding, and I guess our study was limited in that we did not have actual serum bilirubin measurement. This is not always available at Kenyatta National Hospital due to intermittent supply of laboratory reagents, and of course the financial budget of our study did not allow. Similar to other studies, the prevalence of neonatal anemia was not statistically significant. This study was unable to provide any data about severe adverse effects, such as intraventricular hemorrhage, which more recent studies are really bringing out. And of course, we realized we had a lot of limitation in our outcomes that we really would have liked to explore. Until further information is known about the potential adverse outcomes, the use of umbilical cord milking might be an option in preterm infants above 28 weeks who need immediate resuscitation. Further studies, particularly in similar resource settings, are needed, and these should look specifically for intraventricular hemorrhage and include long-term outcomes. Based on this, we said umbilical cord milking might serve as an alternative to delayed cord clamping to achieve equivalent hemoglobin levels, especially in cases where deliveries need to be expedited. This was the first single-center study comparing intact cord milking versus delayed cord clamping in Kenya, and to the best of our knowledge within sub-Saharan Africa. This will hopefully encourage further studies, as a feasibility study within the region and similar resource settings has not been done before. In maternities with a high patient load, limited theatre space, an intervention that can decrease operating time would be really useful to explore. Also, iron deficiency anemia represents a major health problem in low-middle income countries. An intervention such as this, umbilical cord milking, that can prevent neonatal anemia would be useful to explore. A lot of research has come out since this presentation last year, and definitely more research needs to be done, and larger trials still need to be done on cord milking. Generally, the study was well received. I got a lot of feedback and suggestions that were invaluable to drafting a manuscript and to conceptualize ideas for further research. I got to interact with maternal-fetal medicine specialists, students, faculty, and other foundation awardees. It was interesting to compare practices between different parts of the world. In addition, it was an incredible honor to have two of my mentors from Kenya at the conference. That is our head of department, Professor Omondi Ogutu, and my primary supervisor, Dr. Osoti, both from the University of Nairobi. They were both instrumental in guiding me through my project and encouraging me all the way. I really would like to express my gratitude and honor in receiving the Queenan Travel Award and the opportunity to present at this conference last year. I'm both humbled and eternally grateful for the experience. I managed to keep in touch with the foundation organizers who were really great in a seamless process getting me to the conference. Also, Dr. Bagela, he offered guidance on the publication process, post-presentation, and lots of great ideas. It's just been fantastic. The conference was beyond my expectations. Not only was it the largest conference that I had been to, I have to admit it was a little overwhelming to be in the presence of so many highly accomplished physicians. But at the same time, I was incredibly proud and grateful to present my study at such a prestigious event. I gained such strong experiences. I learned a lot and received a great deal of knowledge from interactions with peers at the workshops, lectures, and poster sessions. Thank you, SMFM, for the opportunity of a lifetime. I had taken home many positive messages and shared what I had learned. Without the Travel Award, this experience would not have been possible. And I'm very grateful to the Queenan Fellowships and the Foundation for SMFM for one of the most memorable experiences for me as a young aspiring MFM. I am excited about future opportunities and growing with the society. As we say back home, asante sana, and that means thank you very much in Kiswahili. Thank you.